services provides services to El Paso, Park, and Teller counties. I'm currently the team lead for the Colorado COVID response team, and I'm really happy to be part of this panel.
We're happy to have you, Roberta. Thank you. And Cheryl, you're up next on my screen. Can you introduce yourself?
Sure. Well, I see myself because I don't.
We can hear you though.
Okay. I'm Cheryl Baza. I'm a licensed clinical social worker. I'm also the parent of someone with schizophrenia who has been living with schizophrenia for about 35 years. And so I've had quite a bit of experience with that. Not so much in my practice because I worked mostly with children and families, but I became more interested as other family members had major chronic mental illnesses in that. And I joined NAMI in the early 90s because I was believed that they had a lot of good information and support for families. And I'm here today to speak as a mother of a person with mental illness.
Well, thank you for being here to provide that perspective, Cheryl. Look forward to hearing from you later.
Thank you.
And Lori, you're up next.
Heidi. I'm Lori Jarvis Steinward, and I'm the Executive Director of NAMI, which Cheryl mentioned. It's the National Alliance on Mental Illness, and this is, we're with the Colorado Springs affiliate. We've been around for almost 40 years, since 1983, and we are here for individuals and families who are faced with a mental illness. So we offer all kinds of education and support programs. We help people navigate the local mental health system, particularly if it's new to them, it's the onset of an illness, or there's some sort of crisis where they need support. So I came to NAMI in 2010 as a family member myself. I took the family to family class, which we often call our point of entry program. That's where a lot of people become familiar with the work that we do. So I'm just really happy to be here this evening. I'm happy this book was selected. I'm grateful that the conversation is happening and opening up, and hope that we'll get some great questions this evening. So thanks.
Thank you, Lori. Thanks for being here. And then Carrie, you're next.
I'm Carrie Bolter. I'm with the El Paso County Sheriff's Office. I'm the Behavioral Health Programs Manager there, and I supervise our co-responder team. And that team is comprised of a UC Health clinician, UC Health licensed clinician, and a Sheriff's Office deputy that ride together and partner together 40 hours a week to respond to 911 calls that are mental health related.
Wonderful. Thank you so much. And thank you all for being here. So our next question is kind of broad. What does mental health in our community look like to you? And Cheryl, we'll go ahead and start with you.
I'm going to make this pretty brief and not go into much detail, but I think that we're fragmented and overwhelmed at times. I think the demand for services is greater than the resources that are available.
Thank you. And Lori, we'll go to you next.
Well, I would concur with Cheryl. I think in an ideal world, sort of the ideal vision of what mental health would look like, if we really truly had a healthy mental health system, is those who need treatment and support would be able to get it, would be able to access that care. It wouldn't be as challenging as it is now for people. There would be more providers. We have a huge shortage of providers in our community. And there wouldn't be the kind of wait times that we see people having to experience. And I think there generally will be more acceptance that this is an illness like any other, and there would be less stigma around seeking help.
Thank you. And Roberta, go ahead.
So I can concur with Cheryl and Lori, but I also have another lens, I guess, that gives me a different thought about mental health. And I think it also comes from the book itself and looking at you know, some progresses that have occurred. So although the needs are high, and I see that with the team that I currently work with in terms of the COVID response, there's been a high increase in anxiety as well as depression over the last year and a half during the COVID crisis. And so we do have high needs and there are difficulties with access, but by the same token, we have some opportunities that are there for people. And I think a lot of that comes down to communication and education and making sure that there's an awareness for everyone as to what is available and how to access that. And so I guess I see a little bit of both sides of the fence.
Sure, thank you. And Carrie, how about you?
Well, I have to agree, absolutely. And I think that's the shortage of providers and the high need in our community is what I see through my lens and my job at the sheriff's office is we are responding to people who are in crisis. They're struggling, they're having trouble connecting to resources or finding even the motivation to stay involved in treatment. And so we're probably seeing them on their worst day. We're getting called to individuals who are considering suicide because they don't know that there are other options. So from our lens, it's pretty dire, and we do get to see some of those positives because when we do get to make those connections for people and we can follow up with them later and they seem to be doing better and more stable, but getting them services is difficult.
Thank you all for your perspectives. So we kind of just touched on this a little bit. So there's a stigma around the subject of mental health and having open conversations about it. What do you think can be done to remove some of the stigma associated with it? And then what are some strategies to begin that conversation and bring that conversation of mental health up to people who may still attach a stigma to it? And Lori, we'll go ahead and get started with you.
Okay. Well, I think, you know, if there's a silver lining in the pandemic, and there are some, I think, one of those things that we've seen and experienced at NAMI is across the board, people are generally having more mental health related symptoms, whether it's anxiety, depression, you know, that sense of isolation and loss that a lot of people have experienced have brought on symptoms of mental health conditions that many have never experienced before. So in that process, things have opened up as far as the conversation. We see more people willing to talk about it. There's a couple things that have emerged during the pandemic. Certainly one is, you know, the social justice issues that we've all experienced in the last year. And I think this mental health, the mental health challenges associated with just a global pandemic. I mean, this is not a minor incident in our lives. This is major. It's absolutely life-changing and, you know, transforming our lives. And so, you know, we talk a lot at NAMI about brave space these days, where we have conversations that are open, not just about mental health, of course, but also about the challenges around racial equity. And so I think we're starting to see an opening that applies to some of those topics that maybe have been taboo in the past. And I would say for my generation, that definitely is an opening up. And I know we're going to talk more about younger people, but they are just much more adept and conversant around these conversations. They have managed to defy or, you know, step into and away from some of the stigma that, you know, previous generations have imposed upon ourselves. So I'm hopeful about the opening up of the conversation and just a willingness to speak more openly about what people are truly experiencing.
Wonderful. Thank you so much for that perspective. And Carrie, we'll go ahead to you next.
And what Lori said about this being a global pandemic means that it is affecting everyone in some shape or form. And so I think, and as she's talking about that opens up the conversation. It really does, because everybody is having some sort of impact. Then it's kind of a universal thing. It's when people see or hear about mental health issues and they haven't had that experience, they can say, oh, that's something that doesn't relate to me. I don't relate to that or my family. That's something that's, going on with that family or that person. But this is a stressor that has impacted everyone, and people who maybe didn't recognize that they have similar challenges as others, and so they can relate now, and maybe speaking about those things don't seem as scary because there are other people speaking about them right now. And it's normalized that people are having stress around the pandemic, so it's been normalized for people to talk a little bit more about that stress and anxiety and depression. It's sad that it had took something that was this impacting to kind of create these, well, not really create, but I mean, globalize these conversations. But it is one of the positive things that have come out of this. And then looking at your question about some of the strategies to begin the conversation, it really is that mental health concerns are very similar and should be treated the same way as a physical concern. You have a broken heart, you have a broken leg. And we need to start talking about those things as though they're similar and they're not different, and it's not about somebody being weak.
Absolutely, thank you. And Cheryl, do you have anything to add to that?
I would like to say that we've lived with mental illness in our family now for, like I said, 35 years. And I was a licensed clinical social worker at the time. And I was working for an HMO, and it was difficult to talk with my peers about that. That's probably what led me to NAMI, where I could be more open and talk about it, and also get really good information. And I've seen a real growth in conversation about mental illness over those years, especially in the last 10, I think. I think that as we understand the illness better, we become less frightened by it and want to know, maybe even want to know more about it. I think schizophrenia is still one of those illnesses that is very complex. We may even find in the future sometime that illness is going to be, several other different illnesses. It's been redefined in the DSM-3 for the last 30 years, every 5 or 6 years. They redefine the criteria for this. So I think we're still learning a lot. We need to learn a lot. Some of the other illnesses like anxiety and depression, it's pretty common. Most of us in this high stress society have experienced that at some time or another. So it's less stigmatized. And I think illnesses like autism, they're not as stigmatized as they were 25, 30 years ago. People understand. So I think that's the key. The key is to understanding what the illness is about and having the tools maybe to cope with it. Because even if you do kind of understand it and you can't cope, it's still something that's difficult to have a conversation about.
Thank you. And Roberta, do you have anything to add?
I think they pretty much covered it. I think that when I heard Cheryl and Carrie talk, it made me think of the educational piece from a standpoint of some of the programming that has occurred over the last 10, 15 years, so that we are being able to educate and provide information at levels of entry where people have access to hearing them. So, for example, in primary care settings, it's becoming more common to be able to have behavioral health linked to primary care. And like Carrie said, if you have a broken leg, you attend to it. And if you have symptoms that are bothering you from a mental health standpoint, you should be able to just bring that to your doctor or to someone to be able to help process that with you and connect you to the right resources. So education, being able to provide that so that the scariness that feeds into some of the stigma is diffused. And some of the things we're doing in our team, we're providing presentations to some of the high school students to let them know about mental health, to help them understand symptoms, to help them understand what to create as support, and who are safe people to talk to about things they might be experiencing, and not letting it be a taboo. So I guess those are the things that come to mind as far as how we can try to create more strategies to help. And I think we did that, like Cheryl said, a lot of people I think are more versed in understanding symptoms of depression and anxiety, and maybe have a little less stigma or fear than maybe schizophrenia or other psychotic illnesses, because those are less common. And I think that a lot of people really don't know, don't have any idea what to do when those signs first start to occur.
Thank you all. Okay, moving on to our next question. So for those of who read Hidden Valley Road, we kind of learned that early detection and prevention of mental health issues is key. How do we begin those conversations with young people and their families? And Roberta, you just touched on this, you know, going out to high schools and really showing what the resources are. Does anybody else have anything to add to that?
I think I would just add, Heidi, I mean, as I said earlier, those conversations are happening among young people, and they are oftentimes, I think, initiating those conversations with their parents, because they have the language, they have permission among themselves. It's socially acceptable to talk about, you know, symptoms, to talk about suicidality. I mean, Cheyenne Mountain High School has a mindfulness and positivity club, you know, and that's their focus, is mental health and well-being. And it's become quite popular, you know, during the pandemic, when young people have been faced with so many, really so much loss of, you know, of ritual and tradition and just contact with friends. You know, it's been very socially isolating. So I think if we haven't created those spaces in our elementary schools, our middle schools, our high schools, we need to, and there are certainly models out there for how that is being done and how it's working well.
Great,
My
thank you.
experience has been, as we respond sometimes to the schools for youth that are struggling with suicidal ideation, is that a lot of our schools do have programs in place, some called circles of support, or the one that Lori talked about at Cheyenne Mountain, where they are really helping educate the kids and providing support either through their peers or through counselors that are on site. I think that the next step that would really help with our schools and our community is then bringing that same message to their parents, because our kids are very well versed and they're saying things and they're talking about things that maybe their parents are saying, wait, your boyfriend broke up with you. It's not the end of the world. You'll be fine. And not quite understanding that some of those other things and the behaviors that their kids are engaging in maybe do have more to do with an underlying mental health issue or possible suicidal ideation, even though the triggering event may not seem as big of a deal to us adults, right? So bringing that education to families is really where we should focus, because our kids do really have good language skills around this.
Thank you.
One thing that Carrie mentioned that I would just kind of build on is that notion of peer support, Heidi. I mean, what we know and have learned is that people respond very well to someone other than a clinician at times, you know, really connecting with them and letting them know it's okay to have a conversation. And it's particularly effective if it's someone that you know has experienced mental health conditions themselves. We know there's just a lot of credibility and a lot of connection And a lot of it's very effective, those relationships, those peer relationships. And so I think we're trying to cultivate that more and more. We've done that at NAMI. I mean, that's basically the NAMI formula, but I see it happening across the community in a lot of different places. And it's a very powerful model. And I think and it's cost effective and it's effective. It works.
Thank you, Lori. All right, so as kind of a follow-up to this, readers of the book, Hidden Valley Road, will see that each of the Galvin boys displayed different symptoms and behaviors before receiving a diagnosis of schizophrenia. How does this complicate matters when finding the correct treatment for patients? Anybody who wants to start, go ahead, jump
in. That's a good question for Cheryl. I'm going to punt to Cheryl on that one.
I was just going to jump in, actually.
Good.
Well, I would have to say this, the more serious mental illnesses that we're talking about, which is what the Galvin boys experienced, are harder to diagnose until adulthood. That's number one. And number two, there may be symptoms when kids are when they're teenagers. My son had symptoms as a teenager. He was diagnosed with ADD, ADHD. 15, he was diagnosed with borderline personality disorder. My thought at the time was, well, every 15-year-old has borderline personality disorder. Can you give it? I'm making a joke here. I don't really mean that seriously, but you know, those were the symptoms, and he looked different from other kids in ways, but he didn't meet criteria for schizophrenia until he was older. And so it's a complex disease. I have a brother also with who had bipolar or manic depression. That's what it was called back then. And he was one of the first people to receive lithium as a treatment. And it really, because he'd had pretty much been successful prior to the first breakdown that he had, he recovered within a couple of years. And even though he stayed on lithium for a number of years, he had no more episodes after that. And he lived a fairly normal life because of that. Whereas some people don't. It's much harder for them to live a more normal life. And it's a very, and I think it's difficult because it's very complex. And it's, even as a clinician who has worked with, I haven't worked as much with major mental illnesses as I have in other areas as a social worker. But I think that I have had clients come to me and say, well, I am schizophrenic, bipolar, OCD, and I think maybe borderline personality disorder. And I said, wait, hold on, you know, because they can get, they sometimes misdiagnose themselves, but sometimes they get misdiagnosed too. And so I think that's really key to treatment. I don't like labels. I don't like people calling themselves I'm a schizophrenic. They're a person with schizophrenia, which is an illness. I don't like people calling themselves, I'm a depressed person, when they're more than that. You know, you're more than your illness. And then if you can find the key to what you need that you haven't gotten, maybe a combination of things, good mental health practices, medications, just living a quieter life for some people is really the key. I'm just going to say one thing about that. My son was 4th generation with having the diagnosis of schizophrenia in his family. It was his father's family. I didn't know the other people, but I know that the one that was the first one didn't get diagnosed with schizophrenia because he lived on a farm. He was able to function. His life was pretty peaceful. He didn't have the stresses that kids have today. And I think those are all factors we have to take into consideration in treatment. So having said all of that, let me pass this on to somebody else.
Thank you.
I could say that another complicating factor in diagnosing schizophrenia, any type of psychotic disorder, or even sometimes bipolar or a manic disorder, is that it can appear to others to look like the individual is on drugs. And so they don't necessarily know that individual needs potentially support or mental health treatment, they may brush it off and say, wow, that person's acting in such a way, it looks like they're high on drugs, and not give it another thought. And with some of these disorders, there are times where people can appear normal, and then they will be in a manic or a psychotic state where then people could assume, oh, they must have just taken drugs again. And so I think that's just another complicating factor in getting people the help they need, is really understanding that some of those behaviors and symptoms can be both. It could be drug abuse, it could be a mental illness, and really trying to seek out getting that person support so they can get that ferreted out.
Carrie raises a really good point. We see what we call co-occurring disorders a lot, where people are choosing to self-medicate with street meds or opioids or whatever. But there are times when just the symptoms of the illness itself look like someone is under the influence. And one of the families that we worked with at NAMI, and this is fairly common, they thought their son had significant and major substance abuse disorder, and they were, there was a history of alcoholism in the family. And it wasn't until, a Thanksgiving, when they were all sitting around the table and they'd been together, and they realized he had not, he hadn't ingested anything, but he was hallucinating. He was hearing voices, he was having auditory hallucinations, he was having visual hallucinations. And it wasn't until then that they realized, it was like this moment, this epiphany moment, where they went, there's something else going on here. So I think just staying open, if someone is using substance, just staying open to the idea that this may be self-medicating, they may be self-medicating. So
Great, thank you. So readers of the book see how Lindsay, one of the sisters in the book, took up an advocate role on behalf of her brothers. How important is advocacy? Either, helping people be a self-advocate or having someone be your advocate when you're dealing with mental health issues. And Roberta, we'll go ahead and start with you.
So advocacy is hugely important. When you think about, again, drawing the parallel to medical health, behavioral health is the same. You have to advocate for yourself in our healthcare system. If you think about what it's like to get care from the physical standpoint, and we have a lot more systems in place and a lot more structure in place. So it's even more important with the behavioral health side to have someone there advocating for you if possible, and to educate yourself, try to understand what's going on so that you can be your own best advocate. I think it's also important to know that being able to be in a program that does, if you can get into a program that's got some early intervention. There's a program called First Episode Psychosis, and it's actually defined as an initial episode of psychosis that affects the mind that is blurring reality. And to know that we have programming in place, we have that program at Diversus Health, and it's called Ascent. And being able to know that those things are in place and catching it early so that you can have some wraparound treatment that's inclusive of case management, it's inclusive of education, family education, medication management, anything that helps stabilize that situation so that they have a better future and less apt to have more episodes of psychosis. So to get it stabilized early is really critical. So advocacy, whether it comes from someone else recognizing what's going on and directing you into the right programs, you understanding that, hey, this is in the book, Donald was recognizing some things that he knew were not right, but he didn't know what that was. He didn't know what that meant or why it wasn't right, but he knew it wasn't right. knowing that and being able to talk about what those things are, and advocating for yourself. And again, breaking down the stigma and the barriers helps people do that. But advocating is a huge piece that helps get the right attention and creates the better outcome.
Thank you. Does anyone else have anything to add to that?
Well, I would say that some people, when they're having going through a psychotic episode, and it may last for days, it may last for weeks, it may last for hours, you never know, that during those times they need someone to advocate for them. And so that's why I think it's important. That's my role as a parent, I think, still, is to be an advocate for what I think my son would want for himself when he is stable and can articulate what he wants. He does have a hard time even now, even when he's stable, articulating. So I have to be there, or somebody has to be there for him to help him do that.
Thank you. And we're coming kind of short on time, so I'm going to speed it up just a little bit. We've got lots of audience questions coming in. I want to make sure we can get to those. And Cheryl, I think that this question I'm going to direct to you. So in the book, when the Galvin boys are being diagnosed with schizophrenia, studies in mental illness claim that the parents are responsible. Does this notion still hold true today? And if so, what can we do to stop it?
It was present. It has been around for quite a long time. I think even in the early 90s, you could encounter some even mental health professionals who still believed that schizophrenia was not a valid DSM diagnosis. I'm referring to R.D. Lang and some others. But I think today it's easier. I think sometimes when you've lived with that stigma for so many years, it's hard to shake it loose. And so the best, I guess the remedy for it is, again, education, support, having a place to go. I know there are more school systems that are providing support for kids who are having difficulty in school, who are acting different from others, and having places like NAMI's program for youth, being able to text somebody and talk to them without having to reveal too much about who you really are, so that you don't feel so exposed. Those kinds of things I do think help. And I think the more we know about it, the better off we are, or the better able we are to cope with it.
Thank you. Okay, and I think Carrie will go ahead and start with you on this one. So throughout the book, we see the police are often called in response to the behavior or actions of one of the Galvin boys. What options exist now other than calling the police, and what kind of specialized training have police or sheriff's officers received, and other first responders when they respond to a mental health call?
Okay, there's a lot of things there. I'll try to capture that. So absolutely understandable why 911 gets called. Sometimes the behaviors that our loved ones are engaging in can appear or are very aggressive, or our loved ones could be in a very paranoid state and won't allow their family to help them. And what do we know to do is to call 911 when we need help. Not necessarily the best response for a mental health crisis, but in those times where somebody is quite aggressive, or are they actively trying to harm themselves or others, it is an appropriate response. In our area, we have Diversis has a mobile crisis team that can either virtually do a evaluation on site, and I think Roberta could probably talk more about Diversis's mobile crisis, but that's another option. If they do not want law enforcement, they can call the crisis line and be directed through Diversis, and Diversis will decide how to deploy their mobile crisis. in response to the police training. So we have a training called CIT. It's called Crisis Intervention Training. NAMI is a part of this with us. Colorado Springs Police Department and the Sheriff's Office host this several times a year. It's a 40-hour class. We teach law enforcement about mental health, intellectual disabilities, trauma, juveniles. We also give them a little bit of self-care training. And then we put them through scenarios, about 16 hours of scenarios with paid actors to practice the skills that we have taught them in how to de-escalate somebody who is in a mental health crisis or any crisis, to try to de-escalate the situation so that there's no force used if possible. And so that is a training that is much more popular these days across the country. And then some of our law enforcement agencies like Colorado Springs Police Department and the Sheriff's Office, and now Fountain Police Department, we have our co-responder teams. So we have units that are responding with mental health clinicians, and Colorado Springs also brings a paramedic with them. And so you have those types of responses, as well as a response to 911 being the natural go-to when somebody is in crisis.
Thank you. Roberta, did you want to tag along after that and talk more about the mobile crisis unit?
Sure, thanks. So I was going to put the contact information in the chat. We have the walk-in crisis center, which is located at 115 South Parkside, not far from Memorial Park. And that's a 24/7 facility where you can just walk in and have someone assess what is happening for you, what someone can take you there, you can go there yourself and be able to just see what is going on. And it could be in regard to psychotic episode, but it could also just be something that you're struggling with. So it doesn't necessarily lead to any higher level of care unless that's what's indicated and recommended. But it's something that you can utilize. We also have the ability to come out. They'll send someone out to be able to assess and have a behavioral health person, professional, be able to talk with that person and see what's going on and then make those recommendations from the field as well. So the number to call that, there's a crisis hotline, and someone just put that number and the web page in the chat. There's another number, the 572-6100 number is local, and that also is our main Diversus Health number for anyone who wants to make contact and sign up for services. And again, the first up, the ASCENT team, I want to just make sure that everyone's aware of it because it's part of the education piece that we're talking about in terms of how can we try and let families know what to do when something happens. Because a lot of times what happens is someone might be away in college or go off somewhere, just like in the book, when Donald went to college. A lot of times something may be happening away from their normal support system. And then it's who's going to see that? A lot of what helps in creating the right treatment plan is understanding what symptoms are going on and when things, when one person is seeing this and then they go back and see another healthcare provider somewhere else, there's not a lot of continuity sometimes in terms of understanding what the symptoms are. And if you don't have a good sense of the history, then you don't have as much success in getting the right appropriate treatment. So the first episode psychosis programming that has occurred over the last few years is so helpful and has provided such good outcomes and catches those youth to early adulthood. Anyone from, I think it's 15 to 29 is able to be in this program. And like I said, they have access to the wraparound services that help provide them with some education, work programming, education for their family, their support system, and like I said, medication management. So catching things early and getting a good early response to getting stability is really helpful for someone who's struggling with a lifetime mental illness like schizophrenia or psychotic illnesses.
Thank you, Roberta. Lori or Cheryl, do either of you have anything to add?
Well, I don't know. I was listening to Melissa, and I think that's a very important program. I'm glad to hear that they have that program. I think historically, the mental health community has not been able to provide preventive, and I would say that's a more preventive kind of a program. They're always putting out fires instead of, and instead of trying to prevent what might happen in the future. So good job.
Yeah, I would just say these serious illnesses, the earlier we can diagnose them, just amplifying what Roberta said, the earlier we can get to them, the less sort of, I guess, collateral damage, if you want to call it that, over time. It's these illnesses have their own kind of degenerative quality. So it's really good when someone learns early on how to manage and medicate and get the support that they need. And I would just add that, it really helps to have a community of peers too. We have ongoing support groups at NAMI. We actually have 2 support groups for those who live with mental illness every week, both one virtually and one in person at First United Methodist Church downtown. And it's amazing to see how much this sort of fortifies people who are living with serious mental illness, to know they're going to have that connection with others who understand and walk a very similar journey at least once a week. It makes a huge difference in people's lives.
Thank you. And this is our last question, then we'll open it up to audience questions. So we've talked about a lot of resources. What's available to those who may be experiencing a crisis, a mental health crisis, or know someone who is? Can we just get a recap of all the great resources you all have?
Roberta, you want to talk about Diversis's crisis programs?
Sure. So we have a number of different, as I mentioned, the crisis service, the crisis location is at 115 Parkside, but you can also call and that 572-6100 number, or the 844 number that's posted in the chat. And you can talk to anyone, talk to someone anytime, night or day, and be able to get crisis services. And then they would be able to make recommendations, as I said earlier, for any other kinds of treatment. If it looks like there could be some benefit from some inpatient treatment, we have the ATU, so it's an acute treatment unit that is for several days. It's not a long-term treatment, but it is an ability to help assess someone and stabilize them, and then be able to connect with outpatient services, outpatient treatment, and things like that. So the connection there is making that phone call to either talk to someone or just take someone or go to the lighthouse and be able to see what's going on. It's scary for people, and sometimes they don't know what to do. If it does look like, unfortunately, because of what Carrie was saying about sometimes people having the use of drugs, if it looks like there are some medical concerns or some substance concerns, sometimes they get redirected to the emergency room. But if there isn't a medical concern and if there are no substance issues and someone's experiencing some of those symptoms of psychosis, of hallucination, then by all means take them in and let a professional help talk with them. As I said, I put actually the coactcolorado.org. That has a lot more information for anyone who wants to understand more about what the first episode psychosis programming is about. And it lists all the things, and like Lori said, peer support is huge. And so they not only have the case management and other wraparound, but they are working with a peer who's able to help them. And the peers are able to really talk to them about their own journey and what has helped them, and help some of the struggles and the barriers that they might be experiencing early on in terms of confusion and recommendations. And they're able to help them sometimes where no one else really can help them, because they have that ability to come alongside them, and they feel like they really know what they're going through. So there's a trust factor with a peer, and there's sometimes less of a barrier to the unknown.
Wonderful, thank you. And just any closing or any other kind of thoughts on this before we move to a few audience questions? Okay, we'll go ahead and we'll start with a few questions from the audience. And if you are in the audience, go ahead, type your question in the chat and we'll get to it. So the governor just announced a new program offering 3 free counseling sessions for Coloradans 18 and under. What are the thoughts from all the panelists on this?
How will that be implemented? I would want to know that. How do you connect with the community to offer them those three sessions? I hadn't heard of it.
Great question. I haven't heard of it either until now. Does anyone have more information?
I don't have a lot of information on it. I do think that if it is set up appropriately and then it's advertised in the schools so that kids know about it, I think it could be a good step for those kids who are struggling to maybe talk with their parents, and they can go in and 12 and older can go in and try to get some services themselves. But 3 is generally not enough. So I mean, it's just it's a good gateway opening for our kids to get in, but ultimately I'd like to see our kids be able to have ongoing therapy that need it, and then also that family component if they're not able to talk with their family about it, or there's some struggles there, that there's resources then that can bring the family in and do some family therapy as well. So 3 is great, it's a good start, but it's not going to solve a whole lot of problems.
Well, I would say I would like to tag on to that, Carrie, because I think that if you get referred to the right mental health person, that they will refer you on if they see the need for that. So I think 3 is a good start. I mean, that's enough to get an assessment done at least and have some idea of what might work. And then refer that person on at that point.
All right, it looks like that was our only question. A few other questions had already been answered in the chat.
There's another one here, Heidi, on housing.
Which is very important.
Hold on just a second. Let me pull that up real quick. Sorry. Oh, okay. So what are your thoughts about long-term care / housing for people living with serious mental illness?
Well, there is a need that is unmet in sense of there is housing. long-term care housing, but it doesn't meet the need of everybody in the community that needs that housing. I know from personal experience that it's been difficult for the state hospital to release and place some people back in the community because of the difficulty finding appropriate housing that fits the needs of that person coming out of the hospital. And so that would free up more beds in the hospital if that could happen more readily. So we need to have more resources in the community than we have now. Bottom line is what I'm saying.
Yeah, I would say we've got a few solutions that have opened up, but they're just not enough to meet the needs. Springs Rescue Mission now has some long-term housing, Greenway Flats, but it's just, you know, we've only scratched the surface in terms of the need, and it's an area that that this community unfortunately has not really been able to respond to and rally around in the way that we've needed for a long period of time. There are some things that are definitely starting to happen. You know, there are some housing initiatives that are going to begin to open up more opportunities for people who live with serious mental illness. But generally, I would say this is a place where we have really fallen short in our community, our local community. You see it being done in a way that's much more effective, where people get not just housing, but the wraparound services that they need that go along with housing, that help with stability and everything from occupational therapy to voc rehab to medication management. There are those facilities across the country that treat housing quite differently than what we've done locally. Like I said, the Greenway Flats project at Springs Rescue Mission has been a good example of a local project. And Partners in Housing is beginning to do they're beginning to do some work and kind of scratch the surface on, they have a project that they're working on. So there is some movement, but you know, again, but I think if we start to see how much more effective this kind of housing is, I think that we will start to build some momentum and some will, hopefully some political will, and to make this happen in our community.
And while we wait to see if any other questions come in, does anybody have a final thought or something they wanted to say they just didn't get a chance to this evening? Any kind of closing thoughts from anyone?
I wanted to point out that in regard to the 3 sessions that a lot of us had not heard about, Katie from Diversus Health had put in there that the three free sessions come through providers who are paneled through Signal, and they would be referred then to ongoing care. So Diversus Health's school-based team is going to be able to support that effort. So there's a little more information there about the 3 free sessions, and like she says, Diversus Health has a school-based team that will be connected, that have been connected to the school districts and will be helping support this effort. So I just wanted to make sure everybody saw that in addition to what we talked about.
And then we've got one question that just came in. How do we find primary care docs who specialize in medical care for our loved ones? My son is now dealing with heart issues and muscle weakness due to medication. Does anybody have any tips on that?
I would say work really closely with your insurance provider to ask for, to ask for a provider, seek out a provider who has experience with psychiatric meds. A lot of, of course, psychiatrists have that experience, but if you're looking for a primary care doc, it's really good to find someone who's got some background and experience in psychiatric treatment as well, because the medications do have a lot of complications, the long-term medications for illnesses like schizophrenia and bipolar disorder.
I would agree with that too, because I worked in some clinics where there were some PAs in the clinic that actually had worked more with psychiatric patients than some of the doctors there. So I say that to say that don't dismiss or discount the mid-level practitioners that might be in a clinic, because a lot of times they've had some experiences that have given them a lot of information about medications. So I think it's just important to, like Lori said, you assuming you want to work with your insurance so that you can find something that is affordable, but then within that, interview them and ask them and let them know that these are some of the concerns, and who would be your best person that's had experience with mental health and antipsychotic medications.
Well, and I would add on to that to be even more specific. What are you looking for from the, what are the symptoms that are occurring? Be well prepared when you go to interview someone who's going to provide treatment for you, that that they know what you need. Does that make sense?
Yeah,
I would just kind of reinforce and echo what Roberta said. Sometimes with the shortage of providers that we have in our community, a psychiatrist is not even always the best solution. We've got a lot of physician's assistants and nurse practitioners in our community who who are prescribers, who can prescribe medication, and they actually have more familiarity and better firsthand experience with these medications than a lot of family care docs or general practitioners. So really look for that expertise, because it is it's a very specific kind of expertise.
And we've got one final question. We're kind of running out of time here. So are Diversis and Cedar Springs still the main options for help in Colorado Springs? And does Diversis take health insurance other than Medicaid?
Yes, Diversis Health has a lot of insurance impanelment, a lot of providers that are impaneled to most insurances, Medicaid, and some people who also have Medicaid and Medicare. I think when you're calling to find out about access, you just want to talk to them about what the insurance is and let them know. So we definitely take all kinds of insurance. And I do think, so I know a lot of times, yes, Cedar Springs and Diversis Health have the primary hospitalization options, and other than that, I believe most other places are outpatient treatment.
Well, and I would add Peakview Behavioral Health to that, Roberta, out near St. Francis.
For inpatient?
Yes.
Yes, you're right. Peakview, thank you, Lori.
And we have a pretty strong relationship also with Highlands Behavioral Health, which is in Highlands Ranch, but there are times when there's a shortage of psych beds, inpatient psych beds, and so we do know of other good treatment facilities, psych hospitals in the Denver, particularly the South Denver area.
Yeah.
Well, thank you all so much. Before we wrap up, I want to let everyone know we've got some upcoming events actually with Diversis Health. So we've got a few programs here listed. You can find out more information. Those will all be hosted virtually. Find out more information on our website, and registration is open for all of these programs now. And Roberta, Lori, Carrie, and Cheryl, thank you so much for being a part of this evening. We really appreciate you taking the time to answer audience questions and answer our questions. So thank you all so much.
Thank you.
Thank you.
Thank you for having us.
And thank you all for attending. I hope I learned so much. So I hope everybody, even if you learned one thing, hopefully, thank you for being here this evening. Have a good night.
Thank you.